ankle. So I have my patient on the table still. I want to make sure that we dorsiflex the foot. When we dorsiflex the foot, we do not want the toes to go way up like this because now it's going to be right on top of the ankle joint. So you can see the shadow of the toes right on top of where the malleoli are. So we want to make sure that when they dorsiflex their foot, they still kind of relax their toes a little bit. If you don't dorsiflex the foot, then the joint space will not be open. So you're going to center to the mid malleoli. So these are a really good bony landmark that you can feel. Here's the medial and here's the lateral. You want to make sure that you're right in between them transversely and then longitudinally right in between them to make it sure it's on the joint. I have my left marker on the lateral side. We're going to collimate to 1 inch skin border on the sides. Make sure that we've got the calcaneus on there and 1/3 of the tib fib. And make sure again that the toes are pointing straight up. Usually when they dorsiflex, they point straight up, but you want to make sure that it's not angled this way or this way as well. She's got her shield. All right, hold still, don't move, expose. All right, so now I'm doing the AP oblique internal rotation, the Mortise. So for this one, it's not going to be fully internally rotated 45 degrees like the foot would be. The best way to check this is to make sure that your malleoli are perpendicular to the IR. So the best way for me to feel that is I come down to the heel side, I put my finger on each of the malleoli, and then I get down and I rotate their foot in or out until my fingers are perpendicular to the board. So right now, that looks pretty good.
Parallel.
Sorry, parallel. Thank you. Parallel to the board. So it's not a whole lot of rotation. It's definitely not a full 45. And then again, I'm going to center at the level of the malleoli and just lateral to mid malleoli point. The reason it's just lateral is because if I centered over here, as the leg rotates internally, that I'm not going to be to the center of the body part. So I make sure that my light field is even on both sides. I've got my left marker. I have 1/3 of the tib fib and the entire calcaneus. All right, she has her shield. Hold still, don't move, expose. So now I'm going to do the lateral. So I'm going to have you bend your knee and then roll all the way onto your left side. Good. Place this underneath. I look at her malleola and put that at the center of the cassette. For this one, dorsiflex your foot. We want to make sure that we're not overly rotated, and we want to make sure that we're in a true lateral. So I'm going to have you bring your knee a little closer. You can see how much that changed the position of the foot. So again, tabletop 40 inches, so 43 on the readout. I'm going to center at the medial malleoli. We want to make sure that we've got the tarsals on the film, so 1 inch skin border on all sides. The long axis of the tib fib is parallel with the long axis of the IR. Left marker, she has her shield. All right, hold still, don't move, expose. Now I'm going to do the tib fib. So most patients will not necessarily fit like this. We'll get too close to cutting off the ankle or the knee. So for Julie, I'm going to do it at an angle, and again, use the hypotenuse of the triangle. It gives us a little bit longer distance. We're going to center at mid tib fib. So I basically put my hand on the ankle joint, I put my hand on the knee joint, and where my thumbs meet is where I center. Come on. Let's be tented. There we go. Collimate to 1 inch skin border on the lateral and medial side. Make sure that the long axis of the tib fib matches the hypotenuse of this triangle. Left marker on the outside. Want to make sure that the foot is dorsiflexed and straight up and down. And you need to get the ankle joint and the knee joint. The best way to know that you've got that is the malleoli need to be included. So I've definitely got light past the malleoli. And the knee joint. The knee joint is going to be about 1 to 1.5 inches distal to the apex of the patella, or the bottom of the patella. So her knee joint is right here. So I've definitely got the knee joint and the ankle joint. You start at your 40-inch tabletop, but because this is a very long bone, you can go up to about 46 inches if you need to. So for her, about 41 inches is enough for her. So I'm gonna shield. All right, hold still, don't move, expose. For the lateral, now again, I'm gonna have my patient roll all the way onto your left side, please. Thank you. And however you did the AP, if you do it diagonally like this, then you're gonna do the same thing for the lateral. Again, I'm gonna find the knee joint, I'm gonna find the ankle joint, and right where my thumbs meet is my mid-tib fib. I'm gonna stay right about 41 inches, 1.5 inches distal to the patella and medial malleoli. I've definitely got both joints. You make sure that your light field aligns with the long axis of the bone. Dorsiflex the foot. Make sure that it's in a true lateral. And left marker. Shield. All right, hold still, don't move. Expose.
So this is another view that depending on your clinical site, many places are doing standing knees, even if it's just a routine knee series, not necessarily ordered as a standing. I know the VA hospital does a lot of stuff upright. But for our lab and for our simulation, we are going to demonstrate all of the knee views on the table. Okay, so I would have my patient step up, sit down, and generally when I'm, like Kristen has mentioned before, I would not stand across the room and say, okay, go ahead and hop up on the table. I would be right here. I would be making sure that the stair step was steady, that I have a hand close to her in case she sat down and is about to go off the other side. I just want to make sure that nothing is going to happen to my patient. So I want you to lay down with your head to your right and your feet up to the left there. Okay. Go. Generally, one of the first things I do is put the lap shield on so I don't forget it. That's going to be a helpful tip for your semi-val. And then one of the first things I'm going to do is measure from her. Let me place this hand up on your chest. I'm going to measure from her anterior superior iliac spine, ASIS. So we'll be utilizing a caliper. And you're going to measure from the ASIS to the tabletop. And depending on what that readout is, hers is just over 15. Okay, so you would check in your book on page 342. Actually, come show this. Page 342, it tells you how to determine which, if any, angulation is necessary. So if they are 18 centimeters or less, which she measured 15, I'm going to angle 5 degrees caudad. Between 19 and 24, it's perpendicular. 25 or higher, it's 5 caudad. So based on her ASIS to tabletop measurement, I'm going to go 5 degrees caudad with my angulation. All right, so I have a 10 by 12 lengthwise in the bucky. I'm going to angle now 5 degrees caudad. Okay. And then based on 5 degrees, now instead of being at 43, I would be at 42. Oh, never mind, I'm in the bucky. Okay. So instead of being at 40, I'm going to be at 39 because I've angled 5 degrees. I'm going to come down 1 inch. Right? Okay, I'll line up my laser light to the center of the cassette, and I will adjust my collimation so I see 4-sided collimation. Then I'm going to detent and push my Bucky in. Place my right marker. And you can, at this point, you can adjust the table, you can adjust the tube, whatever situation works best. If the patient had Levi material or some type of heavy canvas, corduroy, anything like that, you definitely have to move the material out of the way. I don't have to do this, but for the sake of just showing the anatomy a little bit better, I'm going to pull her pant leg up.
Guarantees unstubborn.
Okay, and you're going to feel for the base of their patella. If you have trouble, you can always have them bend their knee just a little bit, and I can easily feel the base of her patella now. And my central ray is going to enter 1/2 inch below the base of the patella. So I'm going to have to come down, move my tube just a little bit. Readjust my Bucky. And I want to make sure the long axis of her leg is parallel with the long axis of the table. Her foot should be straight up, not rotated medially or laterally. My central ray is entering 1/2 inch above, 1/2 inch below the apex of the patella. So if 2 fingers is 1 inch, then 1 finger is about 1/2 inch for me. And so that's where I would have my central ray enter. Make sure my right marker is in the field of view, and I would expose there. Then we're going to do 2 obliques, so you would swap out if you had direct or cassette. Radiography, if you have direct capture, you don't have to switch out, but for the semi-val, obviously in this lab, we're gonna have to swap out, get a brand new 10x12 IR. I usually start out with my external rotation, and if you look at how her relaxed leg is, it's already rotated to approximately 45 degrees. So I'm just gonna have her just relax her foot. And I would tell her that, and then generally I don't have to make any further adjustment because a relaxed position is usually about 45 degrees. So looking now at the plane of her leg, I can tell that it is about 45 degrees from the plane of the table. My central ray is still going to enter 1/2 inch below the apex of the patella, but I may adjust it a little bit to make sure that my light field on either side is equal. And place my marker, make sure she's still shielded, and I would expose. That is my external oblique. For the internal oblique, sometimes you may need a positioning sponge to help a patient hold a position. So if rolling her now to where her patella and her leg is now medially rotated 45 degrees, if she was having difficulty holding that position, I could put a positioning sponge under her hip. Oh, it's over here.
Do you also want to talk about the quadrants?
Oh, yeah. Mm-hmm. So I could put a positioning sponge under her affected hip just to assist in making this 45 degrees. So in effect, what we're doing with these obliques is we're rolling the patella. If you had the quadrants of what the collimated beam looks like, her patella now is in the medial quadrant, and on the external, it was in the lateral quadrant. So you can look at the light field and by making sure that the patella now is completely in that quadrant, you know that you've rotated 45 degrees. Right? I'm gonna adjust her in just a little bit, only because I wanna be sure that the long axis of her leg is in the long axis of my light field, placing my right marker, and expose. So we're going to be doing our lateral knee. Depending on your clinical site and the size of your patient, you may see knee series done routinely in the Bucky or routinely tabletop. For purposes of our class and our simulation exams, all of our knee, the AP obliques and the lateral will all be done in the Bucky. Alright, so I'm going to, and this is really, I'm going to show you the textbook way, but what you're going to end up doing is whatever is best and most comfortable for the patient. The textbook has you drawing the uninjured leg forward and bringing the injured leg back just a little bit until the femur is, going down the long axis of the table. If your patient's comfortable and can do this, this is fine. Sometimes it may be better for the patient to leave their other leg bent or drawn backward. I have no preference. I make that decision based on what my patient's able to do. But for purposes of the demonstration, I'm going to show you with the leg pulled forward. Okay, so in anatomy, we're going to talk about the fact that the knee is at its most relaxed position at 30 degrees of flexion. And because we want there not to be any muscle strain on the bones, we're going to be flexing the knee about 30 degrees for the lateral projection. The femoral condyles are going to be superimposed, and the patella, which it's shaped like a half of an egg, the back side of the patella should be vertical, perpendicular to the table. So it's really just some clinic texts will show you to take 2 fingers, and if you can feel the lateral side of the patella with your index finger, then you know you've got enough rotation. Whatever trick works for you is my motto. I just try to estimate feeling the medial and lateral borders of the patella if it's vertical. And to me, with this 30 degrees of flexion, she looks like she's lateral. Now for our AP and obliques, I measured ASIS to tabletop distance to determine the angulation. For the lateral, no matter what their measurement is, you have to angle cephalad, because the femoral condyles the medial one is roughly a little bit larger than the lateral one, so it's already going to be, the shadow of it is going to be larger than the lateral condyle. But now that there's some image OID, some object image distance, not only is it the larger condyle, but it's also going to be magnified. And so by angling cephalad, we're basically taking those 2 condyles and lining them up. So I'm going to angle 5 degrees. And so my SID should now be at 39 because I'm in the Bucky. I'm going to align my tube and detent. Feel for her patella, and my central ray is still going to enter about a ½ an inch below, because I know that's where the knee joint is. You can also look back here at the crease And so I know about what level her knee joint is. And then I'm going to open up my collimation so that I get an inch beyond, and I'm going to include about a third of the femur and a third of the tib fib. And then I would place my marker in the light field. All right, so 30 degrees of flexion, superimposed femoral condyles, lateral patella. My patient is shielded, and I would expose there.